Our second speaker for the endocrine session today is Dr. Mohammad Dubayee, and I would like to welcome him on stage. Dr. Mohammad is an assistant professor in pediatric endocrinology and is a program director of residency training program in Department of Pediatrics. Additionally, he is the chairman of the local committee for supervision of the Saudi Board of Pediatric Training in Central Region.
Okay, assalamu alaikum. Good evening. I would like to start with thanking the organizing committee for giving me this chance to share knowledge and exchange expertise about this very common problem, which is not only in pediatric endocrinology, but also in general pediatric adult as well. Let's start my talk with disclosure. I have nothing to disclose. However, I think this picture, okay, thank you, summarizes the whole talk. Okay, we live in sunny country. Okay, we love sun. However, we are not exposed. As you can see from the hand, she wears gloves. So there is so many barriers to have optimum vitamin D level, and we will discuss this barrier throughout this presentation. Okay, a report from vitamin D deficiency recently has generated great interest in the field, not only among us as a physician, but also among community people. And it is not unusual for anyone who comes to your clinic. He will ask, please, doctor, can you do vitamin D for me? It is very common practice. The number of scientific papers published since 2009 is increasingly talking about vitamin D deficiency. And every year there's an increment 20%, about 20% in paper published about vitamin D deficiency. Systematic review and meta-analysis showed that vitamin D deficiency is linked to ricket in pediatric. Adequate vitamin D decreases the risk of osteomalacia, osteoporotic fracture, fall, and premature mortality. Okay, so let's start first with reviewing the basic of vitamin D metabolism. As you know, we can get vitamin D from two sources, either after exposure to sunlight or from food intake. When there is sunlight exposure, 7-dehydrocholesterol will convert to cholecalciferol, vitamin D3, or we can have it from the diet with ergocalciferol, vitamin D2, or D3 supplement. This forms vitamin D go to liver where 25-hydroxy vitamin D is formed. Okay, and this is the second step of activation of vitamin D. After this, 25-hydroxy vitamin D go to the kidney for 1-alpha hydroxylation, which converts vitamin D to active form and active metabolite. This 1,25-dihydroxy cholecalciferol is the active form. It is responsible for physiological action of vitamin D. And if there is an excess amount of vitamin D, the body has its protective mechanism that converts active form to inactive form, which is 24,25-dihydroxy vitamin D. So the body exerts a protective mechanism against vitamin D intoxication. And this has very important implication when we will discuss management of this common problem, as we will see in a while. Okay, so we have active vitamin D. In order to this vitamin D to have its work, number one, we should have the active form, which is 1,25-hydroxy vitamin D. Second, we should have the normal receptor that can generate the action of vitamin D. Okay, so upon activation or having active form of vitamin D, this will lead to increased intestinal absorption of calcium and phosphorus, increased bone deposit of calcium at physiological doses, and in the kidney, it will enhance reabsorption of calcium and phosphate and decrease excretion of calcium and phosphorus. So the net effect of vitamin D on calcium level, it will normalize vitamin D level in the blood, normalize calcium, and normalize phosphorus. Okay, so there are two main points when we answer the first question, which is the action of vitamin D. We'll speak first about the skeletal action of vitamin D, then about non-skeletal action. Vitamin D deficiency results in abnormality in calcium, phosphorus, and bone metabolism. It leads to decreased effectiveness of calcium absorption from the gut and also phosphorus absorption. This will lead to rickets in young children and osteomalacia later in adult. Also, vitamin D deficiency causes muscle weakness and increased risk of fall. This is in young children. However, in adolescent, before we move to adolescent, let me talk about physical finding of vitamin D deficiency. There is rickety rosary, frontal bossing, skin cupping and flaring of the bone, generalized osteopenia. So I think nobody can miss vitamin D if it is happening in the early life with ricket. Okay? So later on, around adolescent, which is very critical period of normal development and usually missed, because adolescents are missed between pediatrician and internal medicine. What happened in adolescent? What's unique about the role of vitamin D in adolescent period? Okay, we know gain in bone mass during adolescent is the maximum. Okay, there is a yearly increase in spine bone mineral content during adolescent in both female and male. As we can see here, the female, which is in open circle, have the big muscle content of calcium around the age of 12 to 13. However, boys tend to be later on and have higher peak. So the maximum period to strengthen the bone is around adolescent. That's why special care and special attention should be given to this vulnerable period of growth. Okay. There is a positive linear relationship between vitamin D and bone mineral density, and this has been proven by so many studies. When vitamin D improve, bone mineral density increase. So you cannot have normal bone mineral density in adolescent when you have vitamin D deficiency, and this is again very important message. And so what if bone mineral density is low? Do you think this will be reflected clinically? The answer is yes. With each one standard deviation decrease in bone mineral content, there is an 89% increased risk of fracture, and this is very significant. However, the relationship between bone mineral density and fracture risk can be attributed to the underlying etiology or cause. Okay, so this is number one, the skeletal manifestation of vitamin D deficiency. The second one is the non-skeletal manifestation of vitamin D deficiency. It's huge and attributed to so many diseases. It can affect the immune system, upregulation of so many immune process, affect apoptosis, okay, and increase and alter the apoptosis pathway. That's why it can be linked to cancer, and also increase the risk of metabolic syndrome and change or can affect the release of insulin, which can lead to diabetes. And I will not go really into this mechanistic study due to the time constraint. But just I would like to mention that brain, prostate, breast, colon cancer, also immune system, they all have receptor of 1,25-hydroxyvitamin D. So vitamin D is affecting the whole body system. Directly or indirectly, 1,25-hydroxyvitamin D modulate or control more than 200 genes. Okay, so 200 genes of your body, okay, can be affected with vitamin D deficiency, and this is maybe why we have so many publications, we have so many research about vitamin D and its effect on health status. Just some large epidemiological study which link vitamin D deficiency to cancer. This is adult study, both prospective and retrospective epidemiological study indicate that level of 25 hydroxyvitamin D below the 20 nanogram, it's around to 50 millimole per liter, are associated with 30 to 50% increased risk of colon cancer, prostate cancer, breast cancer, along with other high mortality from other diseases. Okay, we know autoimmune diseases are also linked to vitamin D deficiency. People who are living in higher latitude are at higher risk to develop type 1 diabetes, multiple sclerosis, and Crohn's disease. And this was also linked to vitamin D deficiency. Cardiovascular disease, vitamin D deficiency is associated with congestive heart disease and blood level of inflammatory factor, including, and this is maybe related to inflammatory factor like C-reactive protein interleukin 10. So as you can see in the two graphs here, the vitamin D deficient group have higher cumulative risk of cardiovascular event. Okay, so now we'll come to interesting point for discussion. And I will ask you one question about the level or the optimal level of vitamin D. The Endocrine Society guidelines recommend or define the vitamin D deficiency is less than 50 nanomole per liter or 20 nanogram per ml. And vitamin D insufficiency between 50 and 72. Okay, so this is the range of deficiency. Should we be worried about the other extreme, which is vitamin D intoxication? Let me ask the audience, how many of you saw a case of vitamin D intoxication or very high vitamin D level? Just raise your hand, please. So if we have only 2, okay, out of, I think the registration is 1,400. So this is negligible figure. So please, if you take one message from this presentation, be generous when you give vitamin D, at least not less than recommended daily allowance. Vitamin D intoxication is very rare. And I like this quote. Worrying about vitamin D toxicity is like worrying about drowning when you are dying of thirst. So please prescribe vitamin D. Okay, so what's the definition of vitamin D? Why the controversial in the literature occur? Because I think the optimal level of vitamin D which we should aim for depends on 3 things. Maximum suppression of parathyroid hormone. Okay. Number 2, adequate intestinal calcium absorption and fracture prevention. So when we have these 3 elements, we can define the level of vitamin D with deficiency with confidence. So just brief review about the difference of action between parathyroid hormone and vitamin D. We know parathyroid hormone causes calcium release from the bone, okay? Increased renal reabsorption of calcium, increased renal loss of phosphate. So the net effect of parathyroid hormone is increased calcium and decreased phosphorus. The opposite hand, vitamin D increase both calcium and phosphorus, with the net effect increased serum calcium level and increased serum phosphate level. Why it is so prevalent? Why we see vitamin D so prevalent in our community? There are so many risk factors or causes of vitamin D deficiency. Just I will highlight it in brief. We can see reduced skin synthesis, either due to low exposure or increased pigmentation. It can be decreased bioavailability, like in malabsorption syndrome, or due to increased catabolism, like in patients who's taking anti-epileptic medication, or decreased synthesis of 25-hydroxyvitamin D, like in patients who are having liver disease.
Dr. Mohammed, Doctor, 2 minutes remaining, please.
I think it's 14 here. Yeah, okay. So, are you sure what time? Okay, let's go to the second question. When to screen? Recommendation is to screen people at risk, and they are the people at risk. Patients who have ricket, osteomalacia, osteoporosis, chronic kidney disease, hepatic and malabsorption syndrome. And what parameter we should use to screen is 25-hydroxy vitamin D, not 125, 25-hydroxy vitamin D, because it is the reflection of body store of vitamin D. However, there is now recent emerging evidence about the racial difference about vitamin D and the relationship between vitamin D binding protein and bioavailable vitamin D, but it's still a controversial finding. Okay, are we getting enough vitamin D? I think the answer is no. As you can see, the recommended daily allowance range from 400 to 600, and it depends on the cause or the underlying etiology. If the patient has vitamin D deficiency, you need to go the higher dose, like up to 4,500 or 10,000 international units per day until to restore the body store. And don't worry about vitamin D intoxication. There is a study showed taking 10,000 international units daily for up to 5 months, it does not cause vitamin D intoxication. Okay? Treatment, as we discussed before, treatment with 25-hydroxy vitamin D, either ergocalciferol or cholecalciferol, but make sure about the duration and the dose. I would like to conclude with this finding, which is a study we did in Saudi Arabia. It's part of national study about adolescent health called GIRONA study. It is school-based, cross-sectional study, covered the 13 region of Saudi Arabia. It was multi-stage, stratified, cluster random sampling done in intermediate and high school to assess the vitamin D status. Total participants was more than 12,000, and around 5,000 adolescents gave their blood for the test. And guess what? We have around 40% deficient, 55% insufficient, and only 5% sufficient. Okay? So this is alarming, and this is we should pay attention to this result. And this is just about the regional distribution of vitamin D deficiency. Unfortunately, we are not doing any better when it comes to vitamin D deficiency. And this is the previous study. Okay? From 2002 until 2014, all the studies are consistently indicating very low level of vitamin D deficiency. Not only in Saudi Arabia, but also here in Kuwait. There is a recent study published in 2014 by Al-Yahya et al., and the target population was adolescent between 10 to 18 years, and they found 98% have vitamin D deficiency. Okay, what do we need more, okay, to be active in treating this problem? I think with this, I will conclude. I would like to thank you all for your listening.
Thank you, Dr. Mohammed. Any questions? Okay, yeah. Thank you for raising this point. This value, which mentioned by the doctor, what we use in our study, okay? But I am just mentioning here the Endocrine Society guidelines, okay? So again, when we define the optimal level of vitamin D, we have to take the physiological context. We have to take also the racial difference, okay? We know there is a recent study published in New England Journal of Medicine comparing vitamin D level in black versus white, okay? And they found that black people, they have lower vitamin D, higher parathyroid hormone. They have also lower calcium level, yet
compared to white, yet they have better bone mineral density, which is the the reflection, okay, or surrogate marker of physiological action of vitamin D. This raises a question: what is the normal range? Does this racial variability explain or mandate accepting different vitamin D level across races? But I would like to thank you for this question.
I think just there are three experts and 10 worldwide scientists. They agree with this.
Yeah.
I want to know if in case to treat, it's less than 20, but here if we treat, it's less than 50.
No, I think we should stick with the guidelines, which is less than 20. We should treat. Vitamin D very deficient. More than 98% of our population are vitamin D deficient. We have to take proactive movement toward treating vitamin D with all the skeletal and non-skeletal manifestation of vitamin D deficiency. We should not argue about the level. We should not argue about the dose. We should go ahead and start treatment.
Do you give calcium with the vitamin D?
It depends. Actually, you give calcium if the patient have evidence of secondary hyperparathyroidism. If the BTH is high, you give calcium. If the BH is normal, you just replace with vitamin D.
Dr. Mohammed, Assalamu alaikum. What is your recommendation about infant prophylaxis for vitamin D? We are given in our hospital for the first 2 years.
Okay.
Is it recommended?
What's the dose you are giving?
We are giving around 400 international units.
Okay. I think recommendation is good. Recommending 400 to 600, like the Canadian recommendation recommends 600, okay? And some reference at 800 international units per day. And be careful about the compliance. Compliance is an issue, okay? If you give 800, if you recommend 800 per day and the family are not giving, what's the point, okay? So I think for better compliance, I suggest to give 1 ml per week, okay, which if you divide it per week, it comes something like 600 to 800 international units per day. And this improves the compliance and help to keep vitamin D level in normal range. Doctor?
Yes, that question was very similar to mine, actually. It's just whether you thought 400 was adequate, because in Finland they're giving 1,200.
Yeah, sure. So again, Finland is considered higher latitude, and so I think maybe this is, if you give, the study showed that if you give vitamin D, like daily versus weekly versus every 2 months, according to the dose and according to the route of administration, this will help maintaining a vitamin D level. Compliance is an issue in all of our patients. That's why we have to give something that suits our patient. Otherwise, no point of keep discussing about vitamin D optimal level, optimal dose, and the patient are not getting any benefit. Doctor?
Thank you, Doctor. During your presentation, you said we should treat vitamin D deficiency without hesitation, without worry of intoxication. Do you mean by a single dose large therapy, or what we call the STOS therapy, and compared to the usual serial dosage of the normal doses for several weeks? Or is there been any difference between the two types of therapies?
Okay, the STOS dose, which is 50,000 international unit of ergocalciferol, vitamin D2, not D3. Okay, and the study showed vitamin D3 are superior in vitamin D2 when it comes to normalizing vitamin D. But again, are your patient going to take daily vitamin D? I doubt from our practice. So an adolescent study proved the effectiveness of STOS therapy, which is 50,000 international units weekly. And young children, I don't see. However, like I came across some study which mentioning intramuscular injection of vitamin D, of dose of 200 to 300,000, okay, every 2 months. So this was an option, but I think this is a very invasive option to go for.
Okay. Thank you, Dr. Mohammed. We'll move for the next.